Okay, guys. So I think we have like it's 7:04 and we have almost more than 40 people joining. So I'll start with the introduction. So welcome everyone to a new year. Happy New Year to everyone. And 2022. Hopefully it's a better year than last. Uh, the way the few days have gone, I'm not sure how it's gonna go. Hopefully we all get immunized and by this new variant also. So today we are here together virtually and we will be learning about a new procedure known EMBORRHOID. But before that, some housekeeping issues like the code for tonight's talk is 32 work. Don't forget to text it to 828-295-1144 EDS, and as we all know, to get the certification for the hour. In addition to that, just like every month, we have case presentations. Today we have 5 cases, I believe 4 from fellows and one like Mike Stecker, one of our colleagues from Brigham and Women, has an interesting case. And I like this because this is one of the ideas which we have discussed among the boards, that this used to be a sharing spot where anyone who has a difficult case can bring their cases and interact and discuss and get a great opinion from the whole group of IRs. So that's one of the cases. Again, it won't be adjudicated for the price, but that's like a case. And I really like the fact that Mike tried to present this, is trying to present it to us, and he's stuck in cases, so he'll try to make it. And so without much ado, let's talk about our speaker. Today we have the honor of having Vincent Vidal, Professor Vidal from France, Marcel, who's going to talk to us about EMBORRHOID. He is a professor of radiology at University of Marseille, and he did his training in France and Canada. And he's famous for his like leading work in EMBORRHOID, in the field of EMBORRHOID, hemorrhoids. In fact, I also did a few of them and have been in always stay in touch with him, trying to learn new things. So today I think we have a great opportunity to learn like the whole deal with him, and and will hopefully this field is growing. I have talked to a lot of people about this procedure, and like quite a few people are doing all over the country, and this is a good example where we can learn from the expert. And without much ado, I let Vincent take over the screen. Vincent, you want to share or should I share you?
I tried to share, and if there is some trouble with the video, you can. But so at time I cannot share because I don't have.
Let me do that. Let me.
Okay.
So I have your presentation, so not be a problem.
James, you have to de-share so he can share.
Okay, yeah. So I stop share.
And now, Vidal, you can try.
Try now.
Okay. Yeah.
And if you have trouble because you're across the pond, I can put to my share.
Okay, perhaps you will have to share because I don't know why, but I cannot share.
Let me get it started.
Usually it works very well, but especially tonight it do not work.
Try it now. I'm operating from the master account, and I just had changed the option to multiple participants can share.
Right. Yeah. If not, then I'll.
Is that better, Dr. Vidal?
We'll see. Just wait a minute. Share. No, well, it's very strange.
You know what? I can share it if you don't mind.
Yeah, I'm sorry, but I don't know why. It gives me. It does not show me the PowerPoint as usually.
There you go.
Says me like a unknown share. I don't know why. Sorry, so you will have to pass the slides.
Yeah, I have the slides up for you. Okay, good.
Okay.
Can we just pause 1 second? I'm so sorry, Shams. At the bottom where you see it says share screen. Do you see that green button?
Yes.
Do you see the arrow to the right of it?
Yes.
Click on the arrow. In the pop-up above that says who can share, only host or all participants. Do you see that?
You share more.
Okay, the green button, the arrow to the right of it,
Yes,
click that.
it's
And
not
now
letting me.
it says advanced share options, right? Do you see advanced share
Yeah, but
options?
you're sharing right now, so
I'm sharing
Stop
now.
share. Yeah,
There.
okay. Screen share. Exit. If I say screen
Advanced share options next to share screen.
I don't see that.
Do you see the green share button at the very bottom?
Yes, I see.
Put your cursor on that.
Mhm.
There's a caret, a green caret to the immediately on the right side of that. Click that.
I don't see any caret.
You don't see it. Okay, hold on one more second. Dr. Vidal, please try to share again. You should be able to control it now.
When I go with share, it gives me some. I don't know why there is an issue, but that.
So sorry, I've
very
made the
well.
setting so anyone can share. I'm so sorry. Shams, you can proceed as you think is.
Okay. Yeah, so good that we had this lined up.
Okay, so
Okay. Let me know whenever you want to forward it. Okay. You go
I'm
ahead.
really sorry. I'm really sorry
Perfect.
about that. So thank you, Sham, for the invitation. I'm very happy to be with you tonight. It's really a real pleasure to have this possibility to talk with you. So please go on with the slides. Okay, so one point which is really important for us is the physiopathology of hemorrhoids are unknown for interventional radiologists. At the beginning, when I was thinking about using eye hair to treat hemorrhoids, I don't know really what was hemorrhoids. I was even thinking that it was only vein, and finally we will see that it's more artery than veins. But you see there is plenty of different things. So please slides. There is different point. One of the very important point is the increased abdominal pressures, because if you have a big pressure in your abdomen, you will reduce the venous return. So that means that people, well, pregnancy or obesity or things like that, clearly have a big issue with this reduction in venous return. Slide, please. Slides. So the second point is clearly something which is aging. With aging, you have an impaired quality of the collagens, you have relaxation of the connective tissue of anal cushions. So that means that there is something which is clearly only mechanical, and the hemorrhoids will go down with the aging. Slides, please. Slides again. After you have another physiopathologic issue, which is clearly the vascularizations. So you have blood stagnations, and the blood stagnations, you have different things which are important, but one of the biggest physiopathological issue is the arterial hyperperfusion of synucleus. Of course, it's here that we are going to play a role, not on aging, not on hyperpressure in the peritoneum, but here. And if you look at that, you see that spotting, oozing are in this area of the physiopathology. And finally, people who come to have been treated for hemorrhoids, they usually come for that more than for pain, which the first meaning is just, okay, they come more for pain. No, usually we see a lot of people come only for blood. Slides, please. So you see what slides. And for incontinence, soiling and itching, you see that if people come only for that, it's more about aging and about the size of the cushions. And of course, if the patients complain only for that, it will probably not be a good candidate for EMBORRHOID. Slides, please. Slides. Okay, so in 2012, I have seen this technique, which has been developed in 2005. You see this is the Doppler guide hemorrhoid artery ligation, and you see that with this proctoscope, the surgeons or the gastroenterologists go inside the rectum and with an ultrasound Doppler detector, just look for the superior rectal artery. And when he has located the superior rectal artery, just make a suture on that slide. So you see this kind of suture, and they do rounding sutures all around the rectum. So I have spoken with the surgeons at this time and said, does it work, these techniques? He said, yeah, it works well. But you see, it's not so easy, and sometimes I don't listen very well where is the artery. So I put a knot, but I'm not quite sure to do the ligations at the good place. So I said, it's really strange, because for us, coming here with a catheter, we will see all the anatomy, and it will be probably more easier for us to do that than for you. Slide, please. Slide. So I have proposed to do the same thing, going at the same place than the surgeons, but via an endovascular approach, coming in the corpus cavernosum recti, slides, and insert a coil at this place to replace the sutures. Slides. So the concept is really evident and simple, but we have to go back to what is clearly hemorrhoid. So you can see here that on the right side, you have hemorrhoid, which is a normal size. Hemorrhoid, it's a normal physiological network, and it helps to close the sphincters. And you see on the left side, the internal hemorrhoid is too big. It's too big because there is too much blood inside. And you have below the blue line, you have the external hemorrhoid, which is different and gives different symptoms. Slide, please. So as we said, the anal continence and the hemorrhoidal cushions are responsible of 20% of the resting anal pressure. So that means that it is something which is interesting when you speak with the patients. Most of the patients which have a complete removal of hemorrhoids with surgery can have a defect in the resting anal pressure, and it can be a very good candidate for us. Slide, please. So you have three cushions, which are vascularized by small arteries. Slide. The main artery which go to these cushions comes from the inferior mesenteric artery, you can see that, and the superior rectal artery at the end of the inferior mesenteric artery. Slide, please. So here you see the link between the superior rectal artery, the inferior rectal artery, and the middle rectal artery. So this is really a lot of anastomosis. Some anatomical study, which are really old, have proven that 80% of the hemorrhoidal cushions is vascularized by the superior rectal artery. But you have some link, and we are going to see that there is different type of patients. Slides, please. So you see here on this view, the right, the left, it's really common to have the same type of vascularization from the superior rectal artery, which is usually the right and left, and the posterior trunk, where you have usually two posterior branches which are smaller. Slide, please. So here you can see the reconstruction of the CT. We are not used to look at hemorrhoid at CT, but now when you will look at that when you do a abdominal pelvic CT, you can find very easily this kind of small artery. I'm sorry, I cannot show you with my mouse because I don't share the screen, but you see on the left pictures, yeah, you see this is a reconstruction of what you can see on the axial view here. Yeah, so you can really see hemorrhoids. It's not necessary to do a CT before the embolizations, but we have done in one series of 25 patients, we have done CT for all the patients just to see if it was possible to see, and clearly it is possible. Slide, please. So you see here the possibility also to show with MRI. You see these huge cushions, huge vascularizations. If you push on the slide, you will see the area on the MRI. Here, yes, you see the area. Okay, slide please. And here you see the artery and the vein. So even on CT, you can see here the artery, which is small on the red and the drainage vein, which is blue. And you will see after on the left images, the artery and the direct link with the vein is coming up. So we're going to speak about like a fistula or AVM. This slide. So here it is the difference between the internal and external hemorrhoids. So internal hemorrhoids are clearly arterial network. The external hemorrhoids are only vein. So they lead to thrombosis, these external hemorrhoids. They don't lead usually to bleeding. And if it bleeds, it's not red bleeding, it's more venous bleeding. So of course, embolizations will not take care of these external hemorrhoids, but it's usually not a big issue. The issue is more for internal hemorrhoids. Please slide. So there are different kind of classifications to graduate the patients. We will speak about that after because it's really important. You have to imagine that when patients come to consultations, they come, of course, for functional symptoms, and it's really different. Some patients have very few symptoms, but finally they have very stage 4 hemorrhoids, for example, and some people come with a lot of symptoms, apparent symptoms that they feel, and finally they have only stage 2. So we are not going to treat graduations or stage. We are going to treat the patients, and we know that the quality of life and the results of our procedures if the patients feel comfortable 1 year after the procedure. But anyway, you will always have this kind of stage graduations when a surgeon will see the patients. So on the stage 1, you have no hemorrhoid. Stage 2, you have hemorrhoid, but there is no prolapse. Stage 3, you have a prolapse that you can reintroduce. And stage 4, you have a prolapse, which is completely fixed and you cannot reintroduce. If you look at these classifications, when a patient comes with a stage 3 with bleeding, so he complains of prolapse and bleeding. If the surgeons do a surgery and remove the hemorrhoid, of course, he will not have a stage 3 anymore because he will have no prolapse, but he can still have bleeding. So that means that the patients cannot be happy because he still have bleeding and no prolapse. And it's the same for EMBORRHOID. If you treat a stage 4, normally you will still have the prolapse and not the bleeding. So you have to speak with the patients what is the main symptoms for him to be treated. Please, slides. So it's really important. During my faculty of medicine, I have learned that usually hemorrhoids don't lead to anemia. When you have an anemia from GI bleeding, it's always come from a cancer. But you see that 5 to 15% of anemia caused by lower GI bleeding occurred from hemorrhoids. So it's a lot. And finally, we treat a lot of patients which come with anemia, and they have transfusions also. So that means it's not clearly, it's not so rare. Slide, please. So first, in the 60s, there was more thinking that all the trouble was venous hyperpressure hypothesis, like when you have a portal hypertension, sorry. But now clearly since 2000, slides please, the new concept is clearly that there is a high arterial flow. But finally, if you look at the descriptions of the surgery, which has been beginning in the 40s, it's arterial ligations and removal of hemorrhoids. That means that arterial ligations was already naming the name of the surgery. Slides, please. So here is the deep structures of what is hemorrhoid. So you have this small artery which come directly in a venous lake. There is no interpositions of tissue between that. That we call the corpus cavernosum recti. This corpus cavernosum recti creates the cushion. So the role of this is to create a cushion. It looks like a small functional AVM. The role of that is not to bring oxygen. Slides, please. You see here, where is the corpus cavernosum recti? Comes from the suprarectal artery, and after from the small artery. Slides, please. And when you do the angio, you see very well, just up to the anal canal, this kind of small artery. There are tortuous and there are vertical and tortuous. Slides, please. So as we said, the role of this corpus cavernosum recti is not to bring oxygen to the rectum. Is it to create this shunt, to create the cushions and to close the anal canal? That's why when patients come and say that they bleed from hemorrhoids, they would say yeah, there is a lot of bleed in the toilet and the bleed is really red and it makes some spears. So it's really important. This is red blood and clearly it's really symptomatic of hemorrhoids. Slide, please. So some study has been done with Doppler analysis of the artery, of the suprarectal artery in the rectum. So you see on these two diagrams, there are hemorrhoids grade 0 and grade 1, 2, 3, 4. That means that on the left, it's arterial flow, and on the right, it's the caliper of the suprarectal artery. When you have a stage of hemorrhoids, which is 3 or 4, which is the highest illness, you have bigger arterial flow and a caliper of artery, which is bigger. And in this series, I just said, you are not going to develop big artery because you have hemorrhoids, but you have already big artery. So finally, you will have hemorrhoids. Slides, please. More interesting, when you look at the suprarectal artery at the end, when entering in the corpus cavernosum recti, you see that clearly there is a low resistance index in this artery. So clearly it looks like an arteriovenous shunt. Slides, please. Slides. So if you go slides, you will go with, you see the images, you can go on, multiple push. Here you see the direct link between the artery and the vein. So this is a 2 image second. And at 1 image, when it enters in the corpus cavernosum recti, you have no interposal of tissue. You go directly here in the drainage vein. So clearly you see the cushions and the role of the cushions, and it's clearly like an arteriovenous shunt, which is physiological. Slide, please. Okay, so this is for the concept. So we have seen that hemorrhoids are a normal tissue. It's a tissue which has a role. We know how does it works, and we know why it can go to an illness. You have the hyper pressure in the abdomen, you have the aging on the collagen, and you have the hypervascularizations. So now, clearly, we know that surgeons can do only ligations, and it works for some patients. So in 2007, I was speaking with the surgeons and beginning to ask for patients. So I argue with him to say, okay, there is in the literature case report of very small series of embolization of the suprarectal artery for life-threatening bleeding, and it has been a success. I have done some cases also. There's never ischemic complications, so probably we can go on. And there's also a publication which is very interesting, but it's published in Russian. It's not possible to read it. But you see, in 1994, Professor Galkin, which said interventional radiology of chronic hemorrhoids. That was a mystery at this time, but I will tell you more. Slides, please. So I have been lucky, not these patients, but the discussing that with the surgeons, finally one patient come. It was 2 weeks after surgery. The patient had a massive bleeding at home. 2 weeks after removal of hemorrhoids, there was a wound, scale wound, who goes down, and the patients have done a cardiac arrest with resuscitations on the ICU, and they ask us to see if we can do an embolization slide. So, of course, for everybody here looking at that, there is no challenge. It's really easy to go down in the inferior mesenteric artery, and you see at the bottom of the left superior rectal artery that there is some contrast. There is clearly a hole. So it's really easy to come with a microcatheter. Slide, yes, yeah, slide. Come with a microcatheter, insert a very small coils, slide, and block the bleeding. Okay. So finally, the surgeons of our hospital says, okay, I understand that you can do that for life-threatening bleeding. So why not doing that for chronic bleeding? Slide. So the technique was really simple. We do a right femoral root. First I was using Simon's catheter. No, I use a sidewinder catheter. I think it's really easier. And with microcatheter, and I use usually coil or 18 from 2 to 3 millimeters. I use more pushable. I am going to show you because it's more quick and less expensive. Slide, please. So here is the setup in Marseille. I think it's interesting to do a 3D on the end of the inferior mesenteric artery, because after you have your 3D roadmap, so it's not an obligation, but I think it's quite interesting. Slide, please. You see here, so you see very well all the superior rectal artery and the anal canal. Slides. So you have your 3D reconstruction. Slide. And here you have the axial view. So you see how many arteries coming inside the corpus cavernosum recti. Slide. And after I push back the 3D roadmap on the end, you're on the screen. Slide. And here you see the tip of the catheter on the left superior rectal artery. I go as far as possible of the pubic bone. And here you see this small branch below the tip of the catheter, are the very small artery, yes, going down. And you have a small anastomosis, which is the inferior left rectal artery, yes, going to the pudendal artery, yeah. Okay, so I try to put, slides, please. I try to put the coil as far as possible to avoid recanalizations. Sometimes you cannot, but slides, please. So here you have one branch. You see there is another branch which is just around. Slides. So I put another coil. Slides. Here you have left. On each branch, you can have different branch. Slides, please. There is a video after, I think. Okay, you can go on with slides. Slides. Okay, here you see the tip of the microcatheter, the tip of the wire, and the microcatheter coming. You see, I think usually you cannot go further than the pubic bones, but it's clearly the upper part of the anal canal. Slides. So you are in very small artery. You see, when you inject, you can have some small extravasations. Here you have a small extravasation, you see, and you see the link with the inferior rectal artery. Yeah. Okay, slides, please. Slides. So insertion of small coil. Slides. You see that there is some, usually 2 to 3 branch on each side. Slides. Slides. Okay, you see the tip of the catheter, the pubic bone. Slides. And insertion. Slides. I'm sorry that I cannot show you. This is the final control. But if you look at that, you see that there is a small branch coming from the posterior and coming in the middle below the coil. So it's not completely finished. So here, yes, this branch is come and go in the center slide. So you have to go inside the slide. Yeah, and you see here that we find the branch, we put a coil slide. Finally, this is the control. And on the control, you have no more branch which goes below the pubic bone. So this is the goal. That was the first goal that we have to do. The first 3 years we do EMBORRHOID. Slides, please. You see, that was our goal, first goal. Slides. So I show you more how it works with the coils for the younger. So I use usually when I do day procedures, which is 90% of the patients, I insert a 4 French sheet to have small compressions after. So I use a sidewinder. After I use microcatheter, I love a direction catheter, Bern direction microcatheter, because I use it a lot without the wire, because it's very easy. These arteries are not tortuous, not really tortuous, so you can go very quick that. And you see the coils, which are, I use more 2 millimeter and 3 to 7 centimeters of length, and I flush it with water. So that means you have 6 or 7 branches to treat, and it goes really quick because you can flush it. After there is a, you will see here the tip of the catheter is there. So you see that we have done the branch from the right. But, and here you see how quick is it to just insert the coil and flush it with serum. Okay, you see here the insertions of the coil. Okay, so slides, please. Slides again. So we have published the 2 first paper in 2014, which was a proof of concept. So the first patients we have treated was a businessman. He was 45 years old, and he goes to his work with 2 trousers because he knows that he has to change himself because he probably has hemorrhage and bleeding, rectal bleeding during the day, and he has already been at a hemorrhoidal removal with surgery, but finally nobody know what to do with him, and all the first patients was compassionate patients. Slides. So finally, we try to go further with the article in Russian, and after 1 month of research, we have find this guy, which is the Professor Zakashenko, and the Professor Galkin, which was an interventional radiology, and which I think he died in 2015, and just before we go. So he said that he has worked for years on suprarectal artery embolizations. So I went to Siberia in Krasnoyarsk, which I am here in Russia, and they have worked on that, and they have never published in English because I don't know why. But anyway, this guy has done his PhD on suprarectal artery. That's why we can have done publications with them about the safety of what they have done with particles. I will show you after. Slides, please. So when you do the procedures, sometimes you have this kind of images. That means that you do an arteriogram on the inferior mesenteric artery, and you see no big artery coming in the corpus callosum recti. and the patient has symptoms. So that means that there is some things which is not normal. Slides, please. And slide, okay. So here I have bring back the tip of the catheter in the superior rectal artery, and you see that when you inject, you have the middle rectal artery, and after you depict the superior rectal artery. So you see that the size of the superior rectal artery is smaller than the size of the middle rectal artery. So there is clearly a competitive flow, and it's around 30% of the patient which has this kind of middle rectal artery, which are really big. Slide, please. So here is the same. We do the inferior mesenteric arteriogram, and you see there is no artery. Slides. So how can you depict and when can you depict this middle rectal artery? You see on these pictures, we have already embolized the superior rectal artery, and we are coming from the hypogastric, left hypogastric artery in this really, really big artery. Slide. So the best way, I think, when you are here, you don't see very well, you have to go with your catheter, microcatheter, as far as possible of the pubic bone, and you inject. And when you inject selectively, if there is a middle rectal artery, you are going to depict it. Slides, please. Here you see, we inject, and you will see up, you see here, the middle rectal artery. So this is the best way to depict the middle rectal artery. You do the superior rectal artery, you go in the as far as possible, and when you inject, if there is one, you are going to depict it. Slide, please. So here you see the junction between the superior and the middle. Slides, please. Again, you see here you see this is the middle rectal artery, and slides, please. So now on the right, you see the video coming from the middle rectal artery, and you see the backflow coming at the contact of the coil, which has been inserted in the superior rectal artery. So first doing the superior rectal artery, put a coils, and after you go in the middle rectal artery, if you have one. Of course, you imagine all this network, which has not been treated if you don't do the middle rectal artery. So of course, it will lead to no success of the procedures. Slides, please. Slides. So embolizations with cause also. Slides. So we have defined two types of patients. The type 1, where you have 2 superior rectal artery, 1 inferior rectal artery, and 1 middle rectal artery, which is inconstant. If you look at the study, which has anatomical study, which has been done by the prostatic embolization pioneers, Carnavale and Pisco, they said that they have found 25% around of middle rectal artery, which are significant. We have found more in hemorrhoidal populations, because probably when you have a big middle rectal artery, it leads clearly to the pathology. So you have around 60% of the patients which are type 1A, and you have the other patients which are type B, where you have a middle rectal artery, you see the left middle rectal artery, which is bigger than the superior rectal artery. And you see the different angle between the inferior and the middle rectal artery. The inferior rectal artery goes below the pubic bone, and the middle rectal artery go upper the pubic bone. That's like that you can really recognize them. Slide, please. So this is the type 1. You do the superior rectal artery. You don't depict middle rectal artery. Okay, you do embolization of that. Slides. Here is a type 2. You have uni or bilateral middle rectal artery. So on the first images, you have 3 superior rectal artery and a direct link with the left middle rectal artery. And look again, the size of the middle rectal artery is bigger than the superior rectal artery. Okay, slides, please. So if you have a middle rectal artery, of course, here it's really nice to do angio-CT slides, because you want to have, I do a 3D reconstruction. I do the same technique that when I treat, I do a prostatic embolizations. So usually it's more easy to enter in the middle rectal artery than in the prostatic artery, because it's big diameter. Slide, please. So you see here the microcatheter with the superpositions with the 3D slide. Okay, so you can do here via an integrad way, but in some case, perhaps 5 to 10% of the case where you have a big middle rectal artery, you can go from a retrograde way. And here is a specific case. You don't see the corpus cavernosum recti. Slide. When you do injection, you see on the right the link between the superior rectal artery and the middle rectal artery. You see, which is a direct link here. So here, of course, I am going to try to do embolizations from here and not take time to go from the hypogastric. So you see the microcatheter coming backwards in the middle rectal artery. Slides. So here I put some coils in the middle rectal artery. Here I put detachable coils. I don't want to flush coil because if I flush too far, it can go in the pudendal artery. Slides. Look at the injection after you depict some new arteries to the corpus cavernosum recti. So you can do the catheterizations of this artery and do the embolizations. Slide. This is another integrad way. So slide, please. When you are here, you see some suprarectal artery from the left. So the two arteries are embolized. Slide. Here you inject on the right. You see the middle rectal artery, which is here, but there is no perfect link, so you cannot cross that. And the anastomosis is too far, so with only coiling the superior rectal artery, you cannot coil the anastomosis with the middle rectal artery. Slides. So anyway, I finish all the superior rectal artery. Slides. I do the superior rectal artery on the left. Slide. So I have finished all the superior rectal artery. Slides. I go to the right, looking for the right superior rectal artery. Slides. And here you see, so here is the right middle rectal artery. So of course, when you have a type 2 patient, which is type 2 with middle rectal artery, it takes more time. When you have only the superior rectal artery to treat, it's around 45 minutes. When you have a middle rectal artery, it can be more tricky. Slides, please. Okay, and this is a final control slide. So again, just to see, around 60% of patients which are type A and 30 to 40% which are type B. Slides. So of course, you see here the catheter, the tip of the catheter, which is in the left superior rectal artery. You see the link with the middle rectal artery. So the idea that everybody has is to say, okay, I can do coils here and go to the middle rectal artery, but I can also put another embolic agent, which can do the job from here. Slides. So especially particles. Slides. Yeah, if you come here, you will have done the job. So if you have a partial embolizations, it's not good. So what can we use? We can use slides, please. Glue, onyx, particles. So we are going to look at that, and we have done some preclinical test animals. There is a paper which is in CVIR just this month. Now I want to. We have spoken a lot of technique. I want to speak more about the patients and what you have to discuss at the consultation with him. Slide, please. What is the definition of the clinical success? Slide. Clinical experience indicates that the physical appearance of the anal occlusion post-treatment correlates poorly with patient symptoms. What does that mean? Mean that at 1 year, the surgeons look in the rectum and he said, oh, that's strange. There is still a lot of hemorrhoids and the patients do very well. And sometimes it looks and said, there's no more hemorrhoid. And the patient says he has a lot of symptoms. So clearly, the major point is not to look at the rectum, just to ask the patient, are you happy or not? Slide. I show this article because you see it's a paper which has been published in Lancet. You see it is a randomized controlled trial between hemorrhoidal artery ligations versus rubber band ligations. So it's not EMBORRHOID, but it's clearly for 2nd degree or 3rd degree hemorrhoid. It's where we want to be. And in this randomized study in Lancet, the goal was to ask the patient 12 months post-intervention, at the moment, do you feel the symptoms for hemorrhoids are, slide, cure or improve, compare with before treatment, or slide and change or worse. I mean, this is the goal. So the goal is not to say, oh, are the artery bigger? No, do you feel better? Slides. So there are plenty of other symptom severity score, hemorrhoid severity score, incontinence, military pain, surgical complications, need for further treatment. There are plenty of things, but anyway, you have to go with that with the patients. Slide, please. It was strange because when we began, the surgeons discharged patients to us more often because the patients have a lot of bleeding. So I was looking for a bleeding score, and finally there was no bleeding score available for hemorrhoids. That's strange. So we have created a bleeding score with Professor Sapoval, where you have the frequency, the bleeding, the anemia, and the severity. And we have published this score, which has been published with gastroenterologists. And it's really important because patients come, for example, with anemia, and there are very big hemorrhoids. You do the embolizations, and I explain to the patients at the consultations, okay, we're going to treat the symptoms, which is anemia. That means we're going to embolize the hemorrhoids, but we are not going to remove hemorrhoids. So sometimes you can have a small episode of bleeding at the toilet, perhaps each 2 weeks on the paper, or that do not signify that you are not treated. You are treated. And when the patients come back, he said, oh, doctor, sometimes I have episode of bleeding at the toilet. Yeah, but you have 13 grams of hemoglobin and you come from 7 grams. So clearly, to have a bleeding score, it's really important because the patients can see very well from where it goes to where it goes. Slide. So here was the first 5 years of studying around hemorrhoids. So just to look at most of the study are interested about stage 2 and stage 3 of hemorrhoid. The technical success is around 100%. It's not challenging, clearly. Sometimes can be a bit more challenging with middle rectal artery, it's not challenging. The clinical success, you see it's really different. I am happy to have published the lowest clinical success, and I'm not a liar. All the better clinical success is not me. But I think the difference between this clinical success are clearly what is the goal of you as the patient and the time of that. But now the last paper which has been published will show you, say that globally 80% of the patients are satisfied. Most of the theory has been done with only coil or coil with sphere or coil with PVA. Clearly, we don't know yet what is the best, but I'm going to discuss that also. Slide, please. If you look at this theory, if you look at the hemorrhoidal severity score, cushion size, pain, there is no major complications, but it's not really comparable. There is no randomized study. I have asked many funding for randomized study, but it's a bit tricky because the company, every company has the materials to do this kind of embolizations. It's not something which is really like liquid or thing like that. So that means that every company said, yeah, it can be interesting to do a randomized study, but the other company can do it. So That's why finally there is no one company who go, and we had not obtained fund to do that. But one small randomized study has been done in Brazil the last 2 years, which is positive and which would be, I hope, really soon published in the journal. Slide, please. So now this is randomized comparisons, not between patients, but between size of microsphere. We can say now that there is 3 papers which are speaking of size of microsphere. When you decrease the size of microsphere below 500, there are more rectal ulcerations, there are more pain, and there are no more clinical success. So the theory looks for the moment to use particles more than 700 to 900. Slide, please. One theory has been done with liquids. It hasn't been published, it has been presented in a meeting where 15 patients has been treated with glue, and the patients do well. They had no complications. I use a lot of liquids in my practice in hemorrhage, but I am always a bit afraid of liquids in hemorrhage because I am quite sure that can lead to ischemia, and this is still the beginning of the technique. So I think it's I don't say that you have to use liquids for this. Now we have theory of this kind of procedure with transradial access, which is really nice, I think, because the patients come for a day practice, a day case, and with transradial, of course, it's perfect because you have a day case. Just to remember that this procedure is, if you use only coils, the patients feel nothing. It's not painful at the time of insertion. It's not painful after. That means the patient had an intervention on hemorrhoid without pain. Slide, please. Slides. It's only so two meta-analyses has been published, one in CVIR and one in GVIR, which go back with the same results. All the theory now look at mean that 80% of the patients are satisfied. Slide. Always hemorrhage embolizations review. There is clearly one paper each 2 months in the literature. Slides. So one paper which we have to discuss is this paper, which has been published 7 months ago. Annoyed with hemorrhage risk of the EMBORRHOID technique. So it's a paper which comes from Italia, and the paper describes a patient which developed rectosigmoidal ischemia after embolizations. So you are all interventional radiologists. In this paper, we don't know where was the tip of the catheter. We don't know what is the size of the microparticle which has been used. In the paper, it just says microparticles. And the ischemia is not in the rectum, but when you look at the photograph, it's clearly on the same weight. So it's not written in the paper, but someone says me that the embolization has been done at the distal part of the inferior mesenteric artery, which sphere which was lowest than 200. So of course, some sphere has gone in sigmoidal branch and had lead stenosis. So this stenosis has been treated with dilation. But of course, if you do embolizations not in the good place, not with the good agent, you will have complications. Slide, please. So finally, when you look at the patients, you have clearly the good responder. So you do the embolizations. On the left, you have the percentage of symptoms, of cure of the symptoms. And usually the patients, the first week said he is better, but it's not perfect. And it's usually a zone where there's a lot of inflammation. So the reduction of the blood flow, it's not immediate, it's immediate, but it's not immediate on inflammations. And patients say clearly that they do better and better for 2 weeks, 1 month, 2 months. And the best results, which is waiting for Doppler ligations is at 3 months. So we say the same thing for embolizations. And I always say to the patients, don't be afraid if you have some episode of blood the first week, the second week, it will decrease to obtain a good result. At 1 month, most of the patients said they are happy. They can have some small episode of bleeding, but they are very happy. Slide. Slide. So you have some patients which are clearly non-responder. That means that they said, yeah, perhaps some things happen, but not really. But finally, nothing's happened. Okay. So if you have a non-responder, you have to think about, did you miss an artery? Or was it the good indications? Slide. You have an insufficient responder. So that's more interesting because if the patient said, yeah, it's a bit better, but it's not perfect. We'll see. Slide. And finally, slide. Finally, you have the relapser. So the relapser said, okay, I'll do really well for 2 months. And after, I don't know why, but all the symptoms come back. So the relapser and the smaller responder usually are patients where you know that you can do something, you can go to a second embolization, but usually the non-responder, I don't go to a second embolization because that means that I have not treated the good patients. Slide. So why it fails? Slide. It's about indications. So I have shown you these things at the beginning. If the patients come only for pain or for incontinence, you are not going to treat it with embolization. That's clear. Slide. It can be a bad technique. That means if you had a bad technique, if you don't do the middle rectal artery, you can have an insufficient responder or a relapser. Slide. So what do we know so far? Does it work? Now we have the proof in 10 years that it works. Clearly it works on bleeding. The best patients to treat is the young patients which has a stage 2 hemorrhoids with bleeding and no pain. And more of the patients we treat are that. They are young, they have a lot of bleeding, they have no pain, they complain of nothing except bleeding. And the surgeons do not want to treat these patients because they don't know. They say that it's complicated to treat. They prefer to treat stage 3, stage 4. Does it work on pain? Yeah, but if you speak really with surgeons which take care of hemorrhoids, they said hemorrhoid is not painful. It's painful only when you have the crisis. But if patients come to you and say, oh, I have hemorrhoids for years, I cannot sleep, it wakes me at night, it's not hemorrhoids. It's anal fissures, it's hypertony, it's another things. So clearly now when a patient comes and says me, no, I have no bleeding, I have no prolapse, and I have pain, it's awful. I said, okay, I'm not going to treat you because I cannot do nothing, and probably the problem is not hemorrhoids. For prolapse, patients which have stage 3, sometimes the size of the cushions reduce so much that you have no more prolapse, but sometimes it do not work. So this is the same point when a patient comes and say, I have bleeding and prolapse, I ask them, if you want to be completely cured, you need a surgery. The patient said, I don't want to experience a surgery, so I want to have an embolization. Okay, so you will be probably 80% cure for bleeding, and prolapse you will be better, but I cannot say you how much. And the patients understand very well. And after, some of the patients said, okay, I'm okay. The treatment you give me 70% of amelioration of my symptoms, and I'm really happy. And some patients have 90% of amelioration, but finally they said, no, it's not enough because I still have a small prolapse. I do a lot of sports, and it don't hurt, but I don't feel comfortable with that, so I need a surgery. Okay, So clearly here EMBORRHOID is the steps before the surgery. Do the embolizations, it's a day case, it's not painful. And you can slide, please. So the level of evidence slide is still looking for randomized trial. It's intermediate for the moment, slide. One thing which is really important, if you look at this Lancet study that I've shown you, the recurrence of hemorrhoid after Doppler is at 1 year is 30%, and with rubber band ligations is 49%. We are around 25%. So that means that our technique, which is less painful, which is really, I am not going to convince you, you're interventional radiologist. We are fighting with other techniques, which don't give so much good results. So clearly, I think we have a place for that. Slide, please. So for you, if you want to begin the practice, of course, clearly do a good patient selection. Slides. Treat the middle rectal artery if there is one. It's very important. Slides. Use the coils and big particles if you want. I continue to use only coils because of course I have a huge rate, more than 300 now. I don't want to mix the patients, I think, and some of the physicians do coils and it's fair. Probably I will change my mind the next years, because when you have the link that you cannot join directly from the superior rectal artery to the middle rectal artery, you are here, you want to put some spheres to try to do a complete job of that before going to the middle rectal artery. So probably there will be a mix of particles and coils at this time, but be safe. It's not cancer, it's a functional symptom. So one of the most important things is not to kill the technique with complications. If you take a safe agent, you will have safe procedures. Slide. And of course, you need to have a good patient follow-up. Most of the patients we have treated are patients which have symptoms for years and years, for 15 years, and they don't want to experience surgery. So they come and they are really happy to have someone which want to help them, which offer something which is not painful, where they don't have to stop working. So clearly the follow-up is great, and the patient understands very well that if they are not a responder, they can have surgery after. That's it. Slides. Slides. Of course, use the patient's report code from Bremen and valid score. Okay, I think I have finished. Right, so okay.
Thank you. It was very.
I'm sorry that I cannot show you with the mouse, but I think it was better like that because the connection is not as good.
Thank you. It was really, really nice. So if anyone has any questions, now is a good time. We probably have time for maybe one or so question. We have a bunch of talks, like case presentations to be seen. So I'll start. If there are no questions, I'll start with our cases by the fellows. And we have Peter Schaefer from Brigham and Women's. Peter, you want to share a screen, or?
Sure. Let's see if I can share my screen here.
Right.
All right. Was that successful?
Yes, we can see it. Good.
Okay. And it looks okay. I've done the full screen presentation mode, so it looks okay.
Looks good. Looks good. Go ahead.
Okay, terrific. So being mindful of the time, I'll get my stopwatch going here. So I'm going to present a case that's interesting because it's using a technique or a technology that was new to me and it might be new to some of you. So I won't give it away till the end, but just to go through the case, and I'll try to go pretty quickly, being mindful of the time. Thank you to Dr. Mike Stecker, who's on, and you guys are going to get a double dose of Stecker, so maybe I can go even a little bit faster. So the history is, this is a 72-year-old retired teacher with a reported history of systemic sclerosis and longstanding history of non-healing left lower extremity ulcers dating back all the way back to 2012. So now 10 years or so. So she's followed by numerous doctors from numerous specialties. And the consensus based on a lot of diagnostic testing has been venous insufficiency. as the etiology of her non-healing ulcers. And so she's trialed a wide variety of systemic and topical medications. She's had compression therapy and intermittent regression and progression of her ulcers. So I'll go through some of these treatments. And then she's also had numerous interventions. So basically she has very severe chronic pain associated with these ulcers, and they really negatively affect her quality of life. So this is actually an image from 2014 that show kind of classic locations for venous ulcers. So she has some granulation tissue there. They're around the medial and lateral malleoli, and then she has some atrophy blanche from some healed ulcers, and then some skin discoloration. So to go back to 2012, she developed an ulcer in the left lateral ankle, maybe secondary to trauma. She gets a lot of her care on the outside. She lives down on Cape Cod, so it's hard to, her history is a little bit fragmented. So subsequently in 2013, she developed a left femoral DVT in the setting of a meniscus fracture, and she was initiated on anticoagulation at that time. And then the next year, she developed a new left medial ankle wound. So in that context, the lateral ankle wound still was non-healing. So ultimately she underwent a CTA CTV, I think in 2014, 2015, prior to this intervention, that showed possible May-Thurner syndrome. And so she underwent, not with our group, but someone else, she underwent a venogram with IVUS, hemodynamic measurements, and left iliac stenting. And I'll show some images in just a moment, but suffice to say there was complete occlusion of the left external iliac vein with collaterals, and then there was a significant gradient of 5 millimeters of mercury. And then after the intervention, she got near complete healing of her ulcers. So this is the initial venogram, and you can see that there's complete occlusion of the left external iliac vein. These are just delayed images on the right, show that there are a lot of collaterals in the pelvis, and then you can see that the left common iliac vein is likely still open there with some of the collaterals draining into the left common iliac vein. So she underwent reconstruction of the left external iliac vein with stent placement. You can see they got a nice angiographic result at the conclusion of the procedure. So she had also, kind of along this timeline, she had multiple venous duplex ultrasounds of the lower extremities, which showed some reflux in some superficial veins. And so she actually underwent a left GSV EVLT, and her ulcers progressed following that. So she initially presented to our service back in 2017. And we were actually consulted for diagnostic venography. She was referred by a vascular surgeon, and they were evaluating whether they could do some surgical options for her. So I'll show the venogram that we did, an ascending venogram, and it shows complete occlusion of the popliteal vein here. And then up here, you can see a very atretic segment of the femoral vein here. And then further up in the around the left hip, you can see that there's reconstitution of the central left femoral vein, and then the iliac vein stents look like they're still patent at that time. So let's see, moving forward. So subsequently, she stayed with our group, and we did a procedure. We did venoplasty stenting of the left femoral popliteal vein. So we did a reconstruction there. And she continued on anticoagulation. She had a 6-week course of dual antiplatelet therapy, and she did some compression therapy, and she initially improved. But subsequently in January of 2018, she had worsening symptoms. She had a lower extremity ultrasound that showed a complete occlusion of the femoral popliteal stents. And so we revised it. We did pharmacomechanical thrombectomy, venoplasty, and relining of the occluded femoral popliteal stents. But shortly thereafter, on a surveillance ultrasound, she was found to have reocclusion of the femoral stent. So at that point, we didn't feel like there was much utility in terms of trying to reopen those stents. And so we just left them, chronically occluded. So this is from that procedure. You can see the recanalization, reconstruction of the popliteal vein, and then further up the femoral vein, which looked nice and open, restored inflow there. And so subsequently, she had an arterial evaluation. I think she had probably had one to begin with to make sure it was an arterial disease that was causing her non-healing ulcers. Her ABI PVRs were within normal limits, and then she had abnormal toe brachial indices bilaterally from some microvascular disease. So she was kind of at her wit's end with these chronic non-healing ulcers with severe pain. And so ultimately she underwent staged debridements with wound vac plate placement and split thickness skin grafting in 2020. And I can show you some images if, they're interesting to me. There's a little bit of a gore factor here. I don't see split thickness skin grafts all that often, but this is after the placement around October, November of 2020. And then subsequently a year later in November of 2021, about the time that she represented to us. So you can see some recurrent ulcers with some granulation tissue, and then just some pretty severe changes with, you know, chronic scarring, lipodermatosclerosis, et cetera. So pretty gnarly looking ulcers there. So we ordered her for a CTA-CTV just to evaluate the patency of the predominantly the iliac vein stents. And so you can see here, this is a multiplanar reformat that you can show that it doesn't show great opacification of the lumen of the stents, because I think the timing of the contrast bolus and the windowing is not optimal, but you can see that there's these dense calcifications within the peripheral aspect of the stents. And it was read as moderate to severe stenosis with about 75% narrowing. I know that this image doesn't show it all that well, but just, you know, you can imagine, given these dense calcifications, that there's probably, you know, pretty significantly decreased flow through those stents. So we were kind of considering, you know, Dr. Stecker, when he evaluated her, what methods we could employ to regain patency of these stents, venoplasty, you know, different methods of thrombectomy, pharmacomechanical aspiration, and then intravascular lithotripsy. So, which is off-label for venous interventions, but it's FDA approved for arterial interventions and coronary interventions. Or would we use a combination of these techniques? I think, given how calcified those plaques looked, the plan was to proceed with intravascular lithotripsy with a combination of some of these other methods, should the lithotripsy itself not, you know, yield good results. So this just some data in terms of intravascular lithotripsy. It's a relatively new technology. And, you know, essentially, again, all the data is from peripheral arterial disease, femoral popliteal arterial lesions that are densely calcified. And they've had, you know, they've done some basically non-randomized clinical trials, and they subsequently did a randomized clinical trial. And the data is actually pretty good. What it does, it's loaded onto a balloon, and there are multiple points along this 6 to 8 centimeter balloon, I believe, that emit these shock waves. So they get apposition of the vessel wall, they emit shock waves because there's a wire that runs through the balloon, and then those shock waves cause a shear stress on the calcified plaque, and it helps fragment and break up that calcified plaque. So what we did is we did iliocaval venography with endovascular lithotripsy, mechanical thrombectomy, and a balloon venoplasty. So I'm running a little bit over time here, so I'll skip all the technical details and just go straight to the images. So this is our initial run on the first image, and you can see that, you know, actually compared to the pre-procedure CTA-CTV, you know, the stent is more patent than we expected, but you can see along the medial and lateral walls, you can see these these filling defects that are kind of at the sites of where we expected this dense calcium to be. So it's a nice correlation here. And what we did is we actually got left common femoral vein access initially to do our venogram, et cetera. And then we actually got right common femoral vein access to deploy a distal protection device. And we then deployed our lithotripsy balloon, did multiple rounds of lithotripsy within the areas of the calcification. Then we subsequently did an aspiration thrombectomy, which didn't yield terrific results, and the lithotripsy itself didn't yield terrific results. And so we then proceeded with mechanical thrombectomy using the NRA FlowTriever device with a nitinol discs. And this is the post-intervention venogram, which shows, you know, pretty good angiographic result. And this kind of shows you the type of material we were pulling out. So we got a pretty reasonable yield of this kind of chronic calcified and fibrinous plaque. So that's, you know, the case. I thought it might be interesting for folks because I had never seen it before, and it's a relatively new technology. So thanks for having me.
Thank you. Nicely done. It was like, I just had like a small question that, like, do you think the lithotripsy helped in using the Inari post the first step, that Inari was easier on the calcified plaque? I
think absolutely. Yeah, I don't think we would have had as successful a yield without using lithotripsy. And, you know, looking at their data, the data from the trial is actually quite good compared to just plain old balloon angioplasty alone. Doing the lithotripsy prior to doing drug-coated balloon or drug-coated stent placement, they actually got really good results with the lithotripsy prior to those interventions. So I think so, but maybe, you know, maybe just because I'm young and impressionable, that's why I thought it was a good result. And
perfect. Thank you. So I'll invite Katrina Anderson from BI. You wanna share your screen, please? Katrina, are you there?
I'm here. Sorry, I was getting my video going there. So let me share my screen. All right. Can you all see is it full screen or not?
If you go to
No,
presentation mode,
you need to be.
presentation mode will
There
help.
you go. Good.
Oh, I don't
You're
know why
good.
I'm in the middle of my presentation, sorry. All right, here we go. So I'm Katarina Anderson. I'm a PGY4 at BI, and this case is hemoperitoneum 1 month post liver transplant. The attending on the case was Dr. Seth Berkowitz. So it's a 57-year-old male who with insulin-dependent diabetes mellitus and AFib on Eliquis. He has a history of alcohol and NASH-induced cirrhosis, and his status post-deceased donor liver transplant that was complicated by intraprocedural cardiac arrest 1 month prior. He presents to the outside hospital with epigastric pain, weakness, and dizziness, and is hypotensive with a systolic blood pressure in the 70s. His hemoglobin was only 5.8, and his lactate was 3.5. He was treated with 2 units of packed red blood cells, 3 liters of IV fluids, and started on Levophed. Also given 1 dose of Zosyn, and a CT abdomen and pelvis with contrast was ordered. So I'll scroll through this and we can kind of see the major findings that were reported by the outside hospital. And then we'll go through it again a little bit more in depth. Okay. So the acute findings there were a very large perihepatic hematoma that was adjacent to the medial aspect of the liver. That hematoma was compressing the left hepatic lobe, and there were areas of hypodensity consistent with ischemia. But if anyone else was very astute, they may have seen something else. And I want to call your attention to this one slice, particularly this structure here, this hyperdensity kind of saccular appearing structure in the middle of the hematoma, and this more linear area that's pretty difficult to see if you're not looking closely. So we'll take a closer look scrolling through there. Here we have the celiac axis, and I want you to pay attention to the common hepatic and kind of follow the hepatic artery as it courses by the saccular structure here. It becomes quite diminutive and it almost disappears, but then it reconstitutes a little bit better distally. Here again, we see a coronal CT and we can see our saccular structure right here. And it looks like it's, contiguous with this vessel. So the patient ended up being transferred to BI for further management, and IR was consulted for intervention. When we reviewed those images, we noted this structure, and our hypothesis was that this was a pseudoaneurysm arising from the anastomosis. Importantly, this is a recipient proper hepatic to donor common hepatic anastomosis. So we got right femoral axis, and we used a C2 and a Benson wire to get into the aorta. The C2 is used to select the celiac artery. And that was our celiac run. I'll play it one more time. Knowing that we were going to do an intervention, we exchanged our C2 catheter and the 5 French sheath for a 6 French Ansel sheath that we advanced all the way to the recipient's proper hepatic. And we did this cone beam CT, which I think really demonstrates nicely all of the anatomy. So we have our recipient GDA, the recipient proper hepatic is here. And this kind of outpouching right here, that's the anastomosis or the presumed anastomosis with a 2.4 centimeter pseudoaneurysm arising from it. The donor common hepatic artery is this tiny, thin little structure here. This is the donor GDA, and this is the donor proper hepatic with the branches coming off of it. So intervention planning was really key for us here. We only wanted to cross the anastomosis once. It's very fragile and very easy to spasm, so we didn't want to lose our chance to treat here. So you want to know ahead of time before you cross the anastomosis if you're going to coil or if you're going to stent and how you're going to get there. Again, these are tiny, difficult to navigate vessels, so you want to be thoughtful in your instrument selection and your technique. Coiling is one option. It's very effective in terms of achieving hemostasis, but it's very difficult to coil without shutting down the hepatic artery inflow. Because of the dual supply that the liver has, it is possible, especially in a crisis, to do this, but you do risk having biliary complications. The biliary system is highly dependent on the hepatic arterial inflow. And so if you compromise that, you can guarantee yourself that you're probably going to have some biliary complications down the line. Also, risk of graft failure increases. So again, as a temporizing measure, if you need to save a person's life, it's a pretty good option, but you're probably going to need some surgical attention afterwards. The second endovascular technique that we were discussing was stenting. We usually use a covered stent because you don't want flow into the pseudoaneurysm, but this will also preserve the flow through the hepatic artery, assuming you don't get stent thrombosis. The tricky part is that these arteries are, again, small and tortuous, and stenting can be kind of challenging. You have two options with balloon expandable stent, which is a little bit easier to control, or a self-expanding stent, which is nice in a scenario where you don't have regular luminal diameter. And so now we'll discuss what our plan was. Our plan was to exchange an 035 wire for preloaded Prowler microcatheter and a soft Fathom microwire to allow us to gently cross the anastomosis. We wanted to use a covered self-expanding stent because our recipient's artery was about 4.6 millimeters at the proximal end, and the donor artery was about 3.8 millimeters at the distal end. So the self-expanding stent would accommodate that and kind of just expand nicely. The next challenge was stent length. We didn't have a lot of room, and we only had a 5 millimeter by 5 centimeter Viabahn stent in stock. So we had to be sure that that 5 centimeters was going to be sufficient. So in terms of sizing, once we had exchanged our wire for the microcatheter system, we used the Prowler 3 centimeter markers to measure out our distance. So here's one image with, it was a little tricky in terms of where the contrast was, but you can kind of see this is the base where we want to deploy our stent. And then this up here is the hepatic artery bifurcation. So we use these markers just to make sure this is about 3 centimeters. This is greater than 2. Our 5 centimeter stent should fit. So next what we did was we exchanged the Fathom microwire for a stiffer Transcend wire and parked the Transcend in the right hepatic artery for stability. And once we were in place, we were able to advance our stent over that. We did a couple contrast puffs just to make sure our base of the stent was where we wanted it to be, so that when we did deploy it, it wouldn't be way off in the right hepatic artery or the left hepatic artery. So this is our post-deployment run. I'll play it one more time. So as you can see there, we have really nice filling through the, through the stent itself. It's really nicely positioned where we wanted it to be in the recipient proper hepatic and extending proximal to the bifurcation. There's no filling of the pseudoaneurysm, which was very good to see. And then there's the bifurcation, which is preserved. There is a little bit of spasm in the right and left hepatic arteries, but if you noticed at the end of the run, the parenchymal staining was actually quite robust. So in terms of literature, a couple teaching points. Pseudoaneurysm post-transplant incidence is about 0.5 to 2%. Extrahepatic pseudoaneurysms are more common than intrahepatic and account for about 69% of cases. These typically are associated with infection, which our patient did not appear to have, plus or minus technical anastomotic problems. Pseudoaneurysm formation is highly mortal, and there's about 69% mortality. That's even greater if it's a ruptured pseudoaneurysm. Finally, one really interesting case report that I came across was a kind of novel technique, I guess, in terms of treating intra or extrahepatic pseudoaneurysms. And you can always do the surgical route or the endovascular route, but this team actually did a percutaneous thrombin injection that was successful, which I thought was kind of interesting. These are my references, and I'll take any questions. Thanks.
Great. Thank you. Nice case. Very nice case. Is in the interest of time, you should move ahead, and Sam Azizi from MDH will present a case. Dr. Azizi, are you there? Perfect.
Thank you for the great talk and for those great cases. So I'll also try and keep this short and sweet in the interest of time. So my name is Sam Aziz. I'm one of the PGY6 independent IR residents at Mass General. This case was done with the help of my mentors, Dr. Sanjeeva Kalva and Dr. Sarah Zhao. This was one of my first cases I did as a fellow, so it was sort of felt like I was taken into the jungle initially. So it was nice to try to put everything together and really try and study this case before this conference. So my case is a 61-year-old male with history of NASH cirrhosis, portal hypertension, esophageal varices. His biggest complaint is hepatic encephalopathy with multiple hospital admissions. He's been on rifaximin and lactulose titrated to bowel movements for a long time. Despite that, he's had continued episodes of confusion, forgetfulness, and slurred speech. Looking at his pre-procedure CT, it was red, and I'll show you the images, sequelae of cirrhosis with esophageal varices, splenomegaly, and a large splenorenal shunt. He also had a small amount of thrombus in his portal system, and his IMV was patent. On review of symptoms, he's had no episodes of hematemesis or bleeding. He endured some intermittent abdominal pain, nausea, and vomiting. A note is that he did demonstrate asterixis on the physical exam, and the history was obtained from the wife. So on the imaging, these are axial slices, axial CT and portal venous phase demonstrating these splenorenal shunts, and you can see arising from this area, which is the left renal vein, and moving on up, you see at least a few outflow vessels, and here in the portal system in the splenic vein, you might be able to appreciate a few inflow vessels. These are coronal reconstructions of the same images. So here is really nicely demonstrated off the splenic vein into the renal vein. Here's another one. And so I'm showing you these images so you can correlate with the fluoroscopic images to follow. So initially we got transvenous access from the right femoral vein, and our initial indication was to do a retrograde balloon-assisted transvenous obliteration. So transvenous access with a 55 centimeter 10 French Ansel sheath in the left renal vein in the C2. And we kept trying to pacify the structure here, which we thought was the effluent vessel of the varix. We didn't have much success. Eventually, we repositioned the catheter a few times and we extraved. And so we had to really think about our tools. And this was really the best part of this case. So we got transhepatic access. Here's a video of our puncture, a fluoroscopic single spot image of our puncture demonstrating where we were. And this is our portogram in the splenic vein with a 5 French sauce omni demonstrating a few inflow vessels off the splenic vein, at least 3 or 4, and then the nicely demonstrated shunt draining into the left renal vein. So we access one of these large collaterals here, possibly this one, with the catheter, and we did a selective run, again demonstrating the shunt. We then deployed several 0-5 system interlock coils into one of the shunts. And this is our post-procedure digital subtraction angiogram portogram demonstrating inclusion of that area. And of course, as you keep imaging and you depressurize the system, you find more portosystemic collaterals. So here we are embolizing another one in this kind of horizontal plane, again with interlock coils. And then there's a few more here, one right there, and possibly another one even medial to this one. So again, just kind of pruning the garden here. This is a really nice image demonstrating the inflow of vasculature off the splenic vein. And then just that, again, a case to demonstrate all our tools, and this is the point I'm trying to bring home. Balloon occlusion left venogram through the left renal vein with balloon occlusion portogram through this varix, and nicely demonstrating the one side of the varix that you see at the end of this run in correlating the two phases between the transvenous approach and transhepatic approach. So this is our final image after a first embolization with, again, at least 14 or 15 coils deployed in whatever inflow vessels off the splenic vein that we saw. Over time, the patient did have tremendous improvement for about a month. However, after a month, he showed some innocuous resurgence of his symptoms. He continued to be on medical supportive management with lactulose, titrated bowel movements. Of note, when we spoke with him at that time, his ammonia was 101. Previously, it was in the 40s or 50s. So we brought the patient back for repeat imaging, and you see all these coils, and you see some patent portosystemic collaterals. So here's the gonadal vein. If you look in the area of the gonadal vein, there's something that looks similar to the gonadal vein in the area that goes up and connects the left renal vein to the splenic vein, and that is also a patent shunt, and there's a few more, which I'll show you. So this time we got transvenous access again and put a C2 in the left renal vein, and we were able to opacify this varix. We used a Prograde microcatheter, and then we switched over to 018 coils to embolize whatever through retrograde access, embolize whatever collateral portosystemic shunts that we saw. And here we saw a few. On the last image, however, we were really unable to opacify all of the portosystemic collaterals. So again, going back to this case, using all our tools, we did a splenic arteriogram. So we got right-sided femoral access. We put up a C2 catheter, and then we did a full splenic run. And here at the end here, here's the splenic artery opacified splenic parenchyma. And right there, you can appreciate some portosystemic collaterals draining to the left renal vein. So again, using all our tools. And there's a nice correlate. Here's our injection from the left renal vein, again, demonstrating both types of imaging. So the rest of the case, we utilized both a balloon-assisted retrograde transvenous obliteration and coil-assisted. So we put in citrodecol and air and a little bit of gel foam to sclerose this varix, as well as some coils, and let it sit for a while. And our final run was a splenic arteriogram, which did not show that same prominent vasculature arising from the splenic vein. So post-procedure, the patient showed improvement for the next 2 months. However, he has been noted in the recent electronic medical records that he's been getting more confused. No recent ammonia levels and no recent hospitalizations for infection. Again, there's multiple etiologies for hepatic encephalopathy. We were trying to treat one. Learning points for me in this case as a new fellow is know your patient and know why you're doing the procedure. Use your pre-procedure imaging, and lastly, know your tools and how to get the best diagnostic images for your interventions.
Nice, very nice. Thank you. So carrying on in the same vein, we have Brian Coffin from BMC who has a case to present. Dr. Coffin, you're there? Brian?
I am. My screens are competing with each other.
So are you able to show? Or
yes, just give me 1 second.
Yeah, while he's pulling up the case, this is the last fellow case. And after that, we have one case by Mike Stacker, who we all discuss. Okay, thank you.
All right, good evening, everyone. I'm Brian Coffin, PGY3 integrated resident at Boston Medical Center. This is a case courtesy of Dr. Bader, one of our attendings here. This is a prostate artery embolization for refractory hematuria. I have no financial disclosures other than being a resident. So the history for this case is we have a 92-year-old male with hypertension, coronary artery disease, prostate cancer, and BPH with lower urinary tract symptoms, as well as a recurrent urethral stricture. So most of this patient's urologic surgical history occurred at another hospital, and per the report we could dig up from that hospital, his prostate cancer wasn't resected due to his advanced age. Instead, in 2019, he received a green light laser prostatectomy. And then in July of 2021, he received urethral stricture dilation. However, he continued to have persistent symptoms from his urethral stricture. So on December 6th of this past year, 2021, he underwent direct vision internal urethrotomy of his recurrent urethral stricture. Essentially, DVIU is where they directly visualize the urethra and then they insert a blade to cut away the scar tissue they're able to see from the area. Of note, per discussion with our urology colleagues, this is not something that's typically done in the setting of prostate cancer, but it was offered to this patient. And then following this procedure, the patient started having significant postoperative hematuria, which ended up being refractory to continuous bladder irrigation. So shortly thereafter, on the 8th of December, 2 days after the prior procedure, he underwent cystoscopy, clot evacuation, fulguration, and TURP. Despite that, continued to have multiple recurrent episodes of gross hematuria and ultimately required transfusion of 4 units of packed red cells. He was outside of the hospital for a little bit, but then he came back on December 24th, where he underwent repeat cystoscopy, clot evacuation, and fulguration. And then finally, on the 1st of this year, 2022, he presented once again to the outside hospital with gross hematuria and required transfusion of an additional 2 units of RBCs and was transferred to BMC for further care. So in summary, he had significant recurrent gross hematuria following his DVIU, requiring a total transfusion of 6 units over the 1 month since that procedure. Once he got to our hospital at Boston Medical Center, his presentation labs were significant for anemia with a hemoglobin of 6.5, hematocrit of 19.3. His creatinine was elevated above his baseline at 2.22. And his vital signs were significant for some low-grade tachycardia with a heart rate of 107, but he was normotensive at 125 systolic. Patient was admitted, received 1 more unit of packed red cells, now for a total of 7 since his original procedure, and was started on continuous bladder irrigation. However, as before, the hematuria continued to be refractory to the continuous bladder irrigation. And so on hospital day 3, IR was involved at that point, and we elected to proceed with a prostate artery embolization due to his continued ongoing bleeding and likely prostatic origin given his procedural history. At that time, we had not yet obtained any cross-sectional imaging on the patient, and we decided to forego obtaining a CTA given his renal insufficiency that I had mentioned before, and we felt based on the clinical history that there was high likelihood of prostatic origin of the hematuria, and therefore we didn't need the cross-sectional imaging to get started with treating this patient. So now I'll jump to some of our procedural images. This first one is a left hypogastric run performed with a steep ipsilateral oblique. We selected this branch here that we thought was the prostate artery. We confirmed that with a cone beam CT, which is not shown here to save some time, and confirmed that was the prostate artery, as you can see here, with some glandular filling, and then proceeded to embolize it with particles, which were 100 to 300 micron embospheres. And then post-embolization, we had nice cessation of the glandular filling with the contrast. So then we turned our attention to the other side. On the right, we actually ended up having some significant difficulty locating the right-sided prostate artery. So we started with a cone beam, performed more proximally at the level of common iliac. And this ended up revealing a corona mortis. You can see here that we have a common origin of the inferior epigastric artery and the obturator arteries. And then as we go further along, you can see that the prostate artery actually ends up arising from the obturator artery as we move more inferiorly. And finding we did not quite expect on our cone beam CT actually turned out to be the pseudoaneurysm in the prostate adjacent to the prostatic urethra. which based on the clinical history seems to have been an iatrogenic injury from his prior DVIU. And probably the main explanation for his hematuria. So then we did some coronal reformats of the same images where again, we see the common trunk of the inferior epigastric and obturator arteries rising from the external iliac, and that obturator once again giving rise to the prostate artery with some glandular enhancement here of the other side. And then finally, once again, that pseudoaneurysm adjacent to the indwelling urethral catheter. So these are the corresponding digital subtraction angiography images, once again showing that pseudoaneurysm before we embolized. And then post-embolization run is shown here. We used a single Nestor coil and once again the embospheres. We, in the procedure, thought about using glue as the primary embolic due to the pseudoaneurysm. However, given that the patient had not been offered alternatives for treating his prostate cancer or his BPH, we thought it could be nice to try to provide him some additional clinical benefit by using embospheres, which are traditionally used in those settings, rather than just going forward with liquid embolics. So post-procedurally, the patient actually has done quite well from the hematuria standpoint. He no longer has hematuria and has not required further transfusions. And his Foley catheter was removed post-procedure day 1 without issue. He still continues to be, he had a couple other medical problems keeping him in the hospital, such as electrolyte abnormalities. But in all, his GU issues are now resolved. So after this case, we found a retrospective review from Billy and Pisco in Portugal, where they looked at 491 patients who had undergone prostate artery embolization for BPH. Of this case series, 9 of them, which was only at less than 2%, had prostatic arteries arising from the external iliac arteries. But all these cases were identified pre-procedurally, unlike this case that we just went over. In addition, we know that the aberrant obturator origin from the external iliac is fairly common, often occurring 30% of the time. And so it seems that the pre-procedural CTA could be very helpful in identifying these variant anatomies. As, for example, during the case, we had to reaccess on the left, and had we known about the variant anatomy pre-procedural, we would have just directly accessed the left femoral side to begin with. But once again, we had the restrictions of the renal insufficiency at the beginning. If we have time for questions, I was hoping to pose one to the group and just wondering if people are routinely doing CTAs for these patients pre-procedurally. I was discussing with Dr. Bader and learned that there are other institutions such as Dr. Salem at Northwestern where they routinely do a proximal cone beam at the start of every case.
I can take that question. So I do routinely. My standard protocol is a CTA before the procedure, because that gives me a lot of information. In addition, we have worked with the vascular imaging group, and they reformat quite a few of those in certain angles which we like. That helps me minimize my procedure time to like less than 20 minutes of floor time on a routine basis. So the CTA is very helpful, but again, like you can get away with the cone beam CT right off the bat. But I feel like I'm more prepared when I do this CTAs beforehand. Good. So at this point, like I think I don't think Mike would like to be considered for prize. So Vincent, Dr. Vidal, you can decide the winner. Tough work for you all this while. Mike, you wanna set up your presentation all this while. Dr. Vidal?
It's a big responsibility because all the case was very interesting, very well presented. So I don't do any venous this kind of lithotripsy. I don't know about. I do some embolizations of venous anastomosis for portal hypertension. The placement of the stent in the hepatic artery, I think, was really tricky because choosing the good size of the stent was really difficult because there is angulation after it be straight and it's really close from the bifurcation and from the GDA. So probably it's the most difficult case to realize, I think. The other case are, so perhaps hepatic artery.
Okay, perfect. Katrina, I believe you mentioned Katrina Anderson, the hepatic artery.
Yeah.
Congratulations, good job.
Because I think sizing the length of the stent is really difficult in this situation.
Perfect.
Thank you.
Congratulations. Good. Mike, are you ready?
I think so.
Good. Go ahead. You can share the screen.
Share the screen. Is that working or is it showing the wrong screen?
Looks good.
Showing the screen, but it could be a little bigger because anyway, carry on.
Yeah, I think it's showing the wrong screen. I hate these dual screen monitors.
Just go to display settings and choose the other one. That one.
Display settings, swap.
Yep.
There we go. Is that better?
Perfect. That's perfect. Great.
Okay, so this is more of a opinion case that it kind of a challenge that that I have, and I sort of something that I think I want to leave alone, but I'd like other opinions. So this is a 23-year-old, otherwise healthy female who has a known history of absent IVC and a diminutive left kidney. Saw her virtually with really her main complaint was vaginal bleeding that was worse with exercise. She had kind of a long history, but had irregular periods that increased with activity, bleeds for several days, bled 22 out of 30 days the month before I saw her. Also notes some pelvic pressure and sometimes notes some maybe some mild leg swelling. Her GYN had put her on OCPs that had controlled the bleeding, but then switched to progesterone only because she was worried about getting clots and had some weight gain, and then she stopped it about 4 months before I saw her. The GYN had referred her to vascular surgery, but they saw her and didn't really have much to offer, so they sent her to me. And then some further discussion with her. She reported that as an infant, she developed some sort of clot that caused this dysplastic left kidney. She really didn't have any more details, and obviously, since it was more than 23 years ago, it's hard to get that information. Never had any DVT otherwise, but did note that she had a father with a factor V Leiden mutation, but she said hers is negative, and I actually finally found her detailed workup of hypercoagulability, and basically everything was normal. She had a normal BMP, normal CBC. So going back to some additional information that I was able to get using the wonderful Care Everywhere through Epic. On August 2011, she was seen at Tufts Medical Center, Cardiovascular Center, where a vascular surgeon noted she had a large varicose vein on the right abdomen, but no, and at that time had no history of lower extremity varicosities or symptoms. At that time, they got an MRI, which I have not been able to find, that demonstrated this absent IVC, which wasn't a big surprise. Didn't have any symptoms related to that, and basically he said, don't remove the abdominal varicosity, and just leave everything alone since you're really not symptomatic. And because of the effectively solitary right kidney, was followed by nephrology. And nothing really much happened until she reports in 2016, which I'm wondering whether she was a little confused onto the dates, that she saw a vascular surgeon in Cambridge who also got an MRV, noticed absence of the IVC. And again, she wasn't symptomatic, so by her report, they said no intervention. Again, about 4 years later, I was able to find an abdominal MRI done in Norwood, and the impression of the report said mildly heterogeneous hepatic enhancement adjacent to the falciform ligament, consistent with perfusional change, no focal hepatic mass, no signal alteration to suggest hepatic infiltration. But there they again noted the left kidney quite small, which is a known chronic finding, multiple venous collaterals to the hypoplastic infrahepatic inferior vena cava. Fast forward to the referral to vascular surgery where they saw her for the heavy periods. They gave her some compression pantyhose for the mild leg symptoms and sent her to me. So after I saw her, the problem with the old MRV was that it only went through the abdomen, didn't go down to the pelvis where she was really having her main complaint to see whether there were any of these varicosities or any venous collaterals, anything causing a problem from this IVC occlusion. She also had an upcoming appointment with her GYN, which I told her it would be very good to find out what your GYN sees on exam, since they're going to be much more qualified to examine than I am. And basically, she had a completely normal pelvic exam. There were no vaginal varicosities. The uterus was normal. There was nothing going on. And they also got a pelvic ultrasound that simply showed a retroverted uterus that was normal size, had a relatively normal endometrium, no fibroids, and left ovary with some simple cysts and a little bit of pelvic fluid. But again, nothing that would be causing this bleeding. So I had her get an MRV, and I can show a couple pictures. And again, this is the long report that came with it, but essentially here's the right kidney and here's the tiny little left kidney. They did 3 phases on the arteriogram, venogram. So on the arterial phase, obviously everything looks pretty normal. On the venous phase, the vein, the right renal vein is completely occluded and drains into this fairly superficial nest of collaterals in the right abdomen, and then drains into the inferior mesenteric vein, which is a bit odd. And then on the very delayed images, we do see some filling of the left iliac system, which was not too bad up to about the external iliac, and then the common iliac gets very small, and there are a lot of collaterals through the pelvis from the left to the right. And then I think those were feeding up into this nest of collaterals and into the inferior mesenteric vein. And then the right common femoral feeds into this very superficial, probably the superficial epigastric vein, which goes up and is, I think, is draining above the diaphragm, because it doesn't, we don't image above there, with essentially complete absence of the right iliac and IVC below the liver. And then this just shows these large varicosities down in the pelvis with a relatively normal uterus. But if I went down to the cuts through the vagina, there's no varicosities down there at all the way down to the labia. So I spoke directly to her GYN, and really she felt that since the uterus is normal, there were no varicosities, and she did well on the hormonal therapy. We didn't think that the bleeding was due to this venous problem, and they were going to reinitiate the hormonal therapy since that worked before. I did send an INR just to make sure that there wasn't some abnormality there that might be causing the bleeding, although I think that's unlikely, and liver function tests, because I'm a little concerned about all these collaterals going into the liver, although it's venous pressure, so I'm not that concerned. So sort of the couple of questions that I thought that maybe people could help out. So I'm inclined to just leave everything alone. I don't think her bleeding or is coming from this problem. Maybe some of the pelvic pressure and some of the maybe some mild leg swelling wouldn't be surprising, but I think the cure might be worse than the disease if we try to recanalize everything in a 23-year-old and keep it patent for, decades. So really my first question is, should the iliocaval occlusion be treated? And if not now, because I think not now, is there something that could trigger that down the road? Should she go back to vascular surgery for some sort of big surgical bypass? Again, because the kidney itself is occluded, so you'd need to reconstruct the IVC, the renal vein, and the iliac system, which seems like a lot for someone that really doesn't have much in the way of symptoms. Should we just do a diagnostic venogram to kind of get a better idea of what the flow and more detailed anatomy is? Although if we're not going to do anything, probably that's not going to help. Should we repeat the hypercoagulable workup? It was only done in February of 21. Could it be that there were some errors there and she's got some hypercoagulability because she's concerned about being on these oral contraceptives to decrease the dysfunctional bleeding, because she's worried that she has some hypercoagulable disorder that caused all this in the first place, but nothing has come up on workup. What would you tell her about pregnancy? If you had to open things up and now she had stents in there, between anticoagulation and she's worried about compressing the stents and causing it to thrombose. And then all the blood flow from the kidney and the right lower extremity draining into the superior mesenteric vein and into the portal system, is that something to be concerned about in the long term? Or, because it's all venous pressure, it might be a little bit elevated because she's, got some, because she's got the obstruction. But is that something that we need to worry about? Do we need to follow liver function tests and see if she's getting any problems in her liver from potentially portal hypertension? Should we do, transjugular pressure measurements to see whether there's any elevation of her corrected sinusoidal pressure or anything like that? Or, have we solved her problem? We found that her bleeding is not from this problem, and just leave well enough alone. So I don't know if anyone has any suggestions. I'm trying to not make a mess out of this, but she seems to really want to do something, and I really would prefer not to do something.
So Mike, I think I remember this case, and
she didn't see you though.
No, but she saw that. Remember, we're all sort of the same, and this case was presented to us, and she didn't see me because I consulted on this and believed at the time, at least, that this was not worth the extreme amount of work that is going to be required from an endovascular. And that I'll stick a catheter and a needle in anything.
Right.
That in this instance, the risk from this level of endovascular reconstruction was not worth it. And we had a discussion with the vascular surgeons, and I actually recommended that if they were going to do anything, it was going to be a bypass, and that was presented to her, and that as a huge amount of surgery to solve a problem that we couldn't identify at the time. And so I'm pretty sure that was this case, because it's a pretty unique case, and that's why we didn't do anything at the time. Huge surgery, central venous reconstruction, IVC reconstruction in somebody like this, huge surgery, not clear long-term patency, and clearly not a problem, a huge problem that we were trying to solve. And I think that I would not touch her.
Yeah, I agree with Neil. So in my mind, like any IVC reconstruction has to have at least suprarenal patent. In this case, once the renal is down, we are fighting an uphill battle all along. It's like so chronic. It's like probably more than a decade or two old. And we are.
Well, she's only 2 decades old to begin with, so yeah.
Yeah,
but that's right. So that's how she has lived all her life, I believe.
Yeah,
so I don't think we're gonna gain anything rather than just increasing the risk of complications. And I see like the tech chat box, like Shui and others also saying that leave her alone, and I totally agree with that, because
having tried to create a new intrahepatic IVC and instead connecting it to the pericardium, it's not a pretty place to be.
Yeah.
So you don't want to do that. I would leave her alone.
The only thing which I'm concerned about is the liver, as you rightly picked up, and that can be managed with like blood draws and see if anything moved. Then only we have enough reason to go for the pressures and the transjugular biopsy or whatever we need to. Right now, at this point, less is more in my mind, and I
mean,
if
she develops portal hypertension from this, which I think is unlikely, but if she does, I mean, she could get a TIPS or
Correct.
Some
Yeah.
kind of surgical shunt, although I imagine they're still not going to want to touch it.
Well, but then
I mean,
it's
we're
gonna.
talking,
then
I'll
you're
be
solving a
dead or
problem.
retired by then, so it's somebody else's
But
problem.
Mike,
Yeah.
then they're gonna be solving a
Survive that
problem. Right now, I think it would be hard to justify what I consider an extremely high-risk endovascular procedure. It'd be very hard to justify that based on her current symptoms.
No, that's what I thought, but I figured since we had the opportunity of this forum, if I had a bunch of other heads that were smarter than mine that also said this is a no-touch lesion, effectively, that
Michael,
perhaps I could go back, I would go back to her and she would understand that, you know, she's better off as she is not doing anything.
Michael, Clement Grassi here. Just a quick question. Did you say she has any leg swelling?
So again, you know, we're working in COVID times. I've seen her twice virtually. The first time I saw her was while she was commuting to school. She didn't actually give me the time to have a clinic visit. She talked to me while she was driving to school. The second time I actually got her attention, undivided attention in her apartment. But of course, you know, looking at her legs over a camera is with what's reported as perhaps maybe some mild swell. I wasn't going to see anything, so I didn't really waste my time with that.
Sure, yeah, that's reasonable. So I would agree with Neil and Shams, and I think that her multiplicity of the venous collaterals and probably paraspinal collaterals just show what physiologically has naturally developed. And I think in terms of your questions, I personally would repeat the hypercoagulable or do a further hypercoagulable workup, because I think that's relatively easy. But I wouldn't embark at her age on a very extensive recanalization attempt, which might create complications.
Yeah.
Hey, Mike,
All right.
comments. I think whenever there is renal vein occlusion and suprarenal IVC occlusion, gonadal venous flow will recirculate back to portal system. There are congenital communications between the right gonadal vein and superior mesenteric vein, or the inferior mesenteric vein in 5% to 15% of normal adults. So it is similar to when there's a portal hypertension where there may be communication between superior mesenteric venous system and the gonadal vein. Similarly, when the IVC is occluded, the flow can go retrogradely go to portal system. It is very well known, at least I personally have seen at least 5 patients of that kind when there was renal vein occlusion. It is very rare to cause portal hypertension because the flow is not that great. There's so many systemic collaterals taking away lower limb venous flow. So there is no overwhelming flow to the portal system. So patients shouldn't develop portal hypertension. And second question I would like to talk about is the pregnancy. So in patients who have chronic vena cava occlusion, they do become pregnant, they do continue to have normal babies. So I personally don't feel that she should not be stopped from getting pregnant in the future. Yes, there is a higher risk of bleeding because of venous congestion in the internal iliac venous system, but I don't think that should be the reason to stop becoming pregnant in the future. If she
Right. No, my questions on the pregnancy was if you were gonna revascularize her with a bunch of stents and have her fully anticoagulated, that was gonna cause potential pregnancy issues. So would you, put her on shorter acting, but obviously the overwhelming consensus, which seems like the smart thing, is don't touch anything. Therefore, it doesn't become a problem with pregnancies. Other than I suppose she does have all those giant varicosities down there. So if she ended up getting a C-section or something, and they weren't, if they were a little too cavalier, they could get into those and they could end up getting, bleeding problems.
And they need to not be cavalier, yes.
And they need to not do anything with that abdominal wall that's draining the right leg accidentally also, because if that gets ligated, that leg is then she will have swelling.
For sure, yeah.
So,
Great, all great discussion.
right.
So, and
all right,
this is
I appreciate the opinion.
Thanks, Mike. This is exactly what we had discussed in our board meeting the other time when we were discussing that we can have difficult cases where all the experts of the New England area are here, like we see Neil, Sanjeeva, and all, Clement, and everyone. So it's a great pedestal to discuss such complex and difficult cases. Good learning for the fellows also. Again, I will bring the conference to the end with some difficult decisions, because the way I was trying to do this conference this year was like all hybrid. We were doing alternate Zoom and in person. So next February was in person with Ziv Haskell coming. However, the situation is such that we decided that we will probably have Zoom, and Ziv really wants to come, and I like to have him in person. So we are trying to figure out a way to bring one of the other like conference, the speakers on Zoom next month. So I cannot announce anything about that, but in the next couple of days, you all will get email about next month's. Most likely it will be Zoom, and we'll be figuring out who will be talking. The second point is like we have our RFS section, which is doing a career planning session on the 28th of February. So I'll invite all of you guys to be a part of that. It's a great panel discussion and very good learning for the new fellows and the new attendings, where they can learn about the decision-making process during the first few years of their career. And last year we did that. It was very well taken. So I hope we have the similar acceptance this year. And with this, I wish you all a happy new year, and it's already pretty late. So I'll let you guys enjoy the rest of the time with your family. And
Everybody
again,
remember
thanks
to
a
go
lot.
back to EADS to do your survey and
Yes.
print your certificates.
Please, thank you. Okay, I will see you guys in 1 month. Have a good one. Take care.
See you then.
Thanks,
Bye-bye.
Vincent. Bye. Bye. Thanks, Vincent.